Hi, and welcome to the Johns Hopkins Medicine online webinar series. Today we will be speaking about expanding the role of first trimester screening in the era of non-invasive prenatal testing.
Thank you and welcome. Can you hear me? Yeah, great, awesome. All right, just my objectives today is to really review the role of the first trimester ultrasound in the setting of prenatal diagnosis and setting the stage for really much more expanded diagnostic options that we had in the past. I have the disclosures as below. So the first thing that's important is like, where have we actually moved in prenatal medicine, right? Um, this is when I was born, I never had an ultrasound. This year in 1969 was the ultrasound that I got from one of the images in my mother's OB practice. And this is the resolution of ultrasound that you had then. This is a BPD, and this is sort of where we've been in grayscale imaging actually since the 80s. And since that time, multiple imaging modalities have evolved that increase both the precision of imaging, but also the scope of things that can be examined. And so we move from the era of prenatal diagnosis to also understanding the natural disease progression and the natural history of many conditions in fetal life. And that allows us to also grade the severity of the condition, both in terms of prognosis before delivery and afterwards. And that also sets the stage for measuring any risks of prenatal interventions, and that sets the stage to considering prenatal management options. So the premise of prenatal imaging has really shifted now into a different framework where we can say prenatal diagnosis, natural history, prognosis assessment, and options for prenatal treatment or optimized delivery. Now, where does the first trimester scan fit into that? So first trimester ultrasound has been described a long, long time ago, and its primary value was actually improved pregnancy dating that was offered by the crown runt length measurement, and with that, a reduction in post-date inductions. And there was a recognition that you can actually diagnose certain anomalies as early as the 1980s. The big change was when the single operator technique for invasive genetic testing was described by Charles Roddick in the Lancet. And from then on, the focus in the first trimester really focused more on the triage for selecting patients for genetic testing. And that set the stage for enhancing the accuracy of the screening sonogram. And that laid the basis for using the nuchal translucency as a sort of risk triage. At the same time, the utility of a diagnostic sonogram was sort of set more to the side, and the primary research and studies at this time is sort of case reports of what can be diagnosed in the first trimester, and sort of using that as a diagnostic platform was really abandoned because concerns of resolution and differences in presentation. The nuchal translucency established the 11 to 14 weeks platform as a standardized screening platform. And, once the cell-free fetal DNA and NIPT became available, then the importance of the nuchal translucency as a screening parameter to identify patients at risk for, Down syndrome was sort of became less important, but at the same time, having that 11 to 14 week platform actually expanded the capabilities, what you can look at that time. When you look at the recommendations of the professional societies today, basically they all recognize that the first trimester is essential to confirm the position, the viability of a pregnancy, provide accurate pregnancy dating is absolutely critical in multiples to determine the chorionicity. It can be used for screening for aneuploidies. And also, if the expertise exists, identify major structural abnormalities, and you can screen for placental adhesion disorder and preterm preeclampsia, which is something that I will not be discussing here right now. Now, there are some important, landmarks in imaging and the correlation with pregnancy that are important to recognize. Typically, you'll be able to identify a gestational sac once the HCG is at about 1,000 milliunits per ml. And once you reach HCG of about 2,500, you should be able to see a yolk sac if it is an intrauterine pregnancy. And the crown rump length is typically, or a fetus should be identified somewhere in the region between 5,000 to 17,000 milliunits per ml. And the dating accuracy is the greatest once you can actually measure a fetus physically, which in the early gestation is about plus minus 3 days. The optimal screening that has been recommended by a professional society basically is between the 6 to 11 weeks, where you can use the CRL, and the recommendations how you should use it vary a little bit. ACOG says average of 3 CRL measurements. ISWOG places more emphasis on a good quality image and just taking that optimal image. Organogenesis is completed to a degree that it actually allows a detailed examination of early fetal anatomy in that gestational age window where the CRL is between 45 to 84, which marks the gestational age window where the first trimester screen is generally conducted. So imaging platforms in the first trimester is that between 5 to 7 weeks, you should be able to confirm a singleton with a heartbeat and able to assess the number of fetuses as well as the chorionicity. Typically between 7 to 14 weeks is when you can use the crown rump length, and the dating accuracy is highest in the window between 7 to 9 weeks, and after that it is a little less accurate. The optimal time to determine chorionicity by looking at the lambda versus T signs is also in the first trimester, and this is absolutely critical because it determines when, how frequent you should screen these pregnancies. The nuchal translucency is sort of the first focus that people had a lot in this 11 to 14 week window, and the focus was transitionally always that it's a marker for aneuploidy. But the nuchal translucency is actually associated with many, many more abnormalities. So its value, or looking at it in a standardized way, is not just really to say like, well, this is a high risk for Down syndrome. It actually can point to many other conditions, some of which are only identifiable by invasive genetic testing beyond the karyotype. Now, in combination with additional markers that look at the ductus venosus Doppler and the tricuspid regurgitation, it has a relatively high sensitivity at a 4% false positive rate for the major aneuploidies as well as Turner syndrome. And that's kind of where I'm going to leave it with the nuchal translucency screen. Now, the plane that identifies the optimal nuchal translucency also allows you to look at the intracranial translucency, which is the dark area that is behind the medulla oblongata and the brainstem. And this is the area of the fourth ventricle, and its obliteration is associated with open spina bifida, which you can sometimes physically see if it's a large defect, but it is certainly something that goes beyond the genetic, screening potential of the nuchal plane. The first trimester ultrasound examination, if performed looking at the fetal anomaly, uses several imaging planes. So the sagittal of the face, looking at the cord insertion. The placenta is part of the first trimester examination. The BPD and head circumference measurements at the BPD plane of the head also allows you to look at the ventricles and the choroid plexuses. Looking at the thorax and especially the cardiac axis is an extremely important screening plane. And I come back to that. Looking at situs, the position of the stomach, the liver, and the abdominal circumference. Looking at bladder diaphragm, spine, abdominal wall, and bladder filling. These all constitute parts of the basic anatomy in the first trimester, including identification of the extremities. Additional specialized views where you basically look at cleft palate and also looking at the hindbrain and the addition of color Doppler and looking at the kidneys and the perfusion of the pelvic organs with color Doppler sort of distinguishes the basic of the detailed anatomy. So there are several things that are important when considering making physical diagnosis in the first trimester. Many conditions that are very readily picked up later on may appear different on the first trimester ultrasound, which is really sort of one of the reasons why people were reserved about using it. First of all, in the fetal calvarium has a similar echo density as the underlying soft tissue at around 11 weeks or so. So even if you have anencephaly, it might be difficult to distinguish. And one thing that is very, very typical in the first trimester is that you might look at an image where you have sort of a very poor definition of the cranial outline. And when you look a few days later, you might actually clearly see this abnormal appearance where you have the brain that's basically not normally formed. So this is sort of a very typical course for first trimester anencephaly. So anencephaly might be difficult to diagnose at around 10 or 11 weeks, but it is usually apparent in most of the cases by sort of 13, 14 weeks. Other anomalies that are readily appreciable is the holoprosencephaly, if it's of the alobar type, because you have a monoventricle, and the proboscis or a single eye can be suspected when you do the midfacial view that you also use to look for cleft palates. Encephaloceles are pretty well visible in the first trimester by an abnormal outline of the skull. These are important because they are associated with autosomal recessive conditions such as Meckel-Gruber syndrome, which can also be associated with polycystic kidneys and polydactyly. Hydrocephaly is difficult to diagnose in the first trimester because the ventricles are relatively large and you should really look more at the ventricular hemispheric ratio, and the traditional sort of cutoffs that you use for ventriculomegaly really become more applicable in the second trimester ultrasound. So in the first trimester, if you have suspicion, you really need to look at the ratio. The retromaxillary triangle, so this view of the face is really, really important because although you may not be able to see a cleft lip, this allows readily to identify a cleft palate. If the palate, the sort of horizontal echogenic line is interrupted, as in this view with bilateral cleft palates. Cleft palate is important because cleft lip, if it's isolated, is associated with more cosmetic defects, but from a speech development, not as devastating as a cleft palate would be. So in a way, the first trimester is actually easier to identify the bony defects when compared to the second trimester. GI abnormalities that are pretty well identifiable after 11 weeks or so if there's an abnormality in the stomach or if there is problems like omphalocele. The midgut herniation, which is basically where part of the gut is herniated into the base of the umbilical cord, physiologically disappears by 12 weeks gestation. So that makes abnormalities such as omphalocele and even gastroschisis readily diagnosable. Omphalocele with a closer relationship with traditional aneuploidies. If you look too early, so if you look at 10, 11 weeks, the disadvantage is that you could have something that looks like an umbilical hernia or an omphalocele. And if you're seeing a finding, even as marked as this, at 10 weeks or so, it may be better to get them back when the patient's about 12 weeks, because in some cases, this might disappear. Other abdominal cystic structures that we can observe is bowel malrotation, colodocal or liver cysts. When we're looking at the kidneys, so kidneys are first visualized very early on in pregnancy, but they have a high echogenicity that makes it sometimes difficult to distinguish. So the addition of color Doppler is complementary because it identifies the renal arteries. When you have adult polycystic or infantile polycystic disease, it might not show up as cysts in the first trimester, but rather with enhancement of the physiologic echogenicity. Renal agenesis can be difficult to diagnose because the fluid around the fetus is typically normal in the first trimester, but here doing Doppler, either with power Doppler or regular color Doppler, can be helpful because it can confirm the absence of renal arteries, which should be present in a region where you suspect the kidneys. Now, megacystis is an important finding, and it has different associations depending on the degree of distension. So megacystis is typically when the longitudinal length of the liver, of the bladder exceeds 8 millimeters, and it's further graded into mild, moderate, or severe. When you are looking at mild megacystis, typically the majority of these patients' findings resolve. When you have a moderate megacystis, this is more likely associated with aneuploidies, particularly if the nucleotranslucency is also elevated. And when you have a severe megacystis, that is often associated with obstructive uropathy and might be associated with more complex genetic abnormalities beyond just aneuploidies. And this is important to remember because the first trimester fluid might be completely normal, even in urethral atresia, because the fluid is produced by the membranes and the placenta. So the presentations of renal disease specifically are distinct from the second trimester. Now, another important screening platform or another important organ system to screen for in the first trimester is the fetal heart. So doing the ductus venosus Doppler and the tricuspid regurgitation actually allows you to identify babies that are at high risk for major cardiac disease. And although this is not diagnostic, when you identify a subset of patients with a high pre-existing probability for cardiac disease, then doing a first trimester echo is actually effective because you're going to identify a fair amount of cases because they are high risk collective. Of all the imaging markers in the first trimester, the one that has the strongest association with congenital heart defects is the cardiac axis. And this is important because it can be easily done at a four-chamber view. And as a rule of thumb, the normal axis is about between 30 to 60 degrees from the line that horizontally or vertically bisects the thorax. Another important marker for cardiac abnormalities is the first trimester fetal heart block. In the first trimester, it is rare, even in a patient with Sjogren's syndrome, to get a complete heart block because the passage of autoantibodies is not that good this early on. So if you actually get a complete heart block, it is far more likely to be associated with a cardiac abnormality and many times heterotaxies with AV canal abnormalities. And Other things that increase your pretest probability are obviously pre-existing maternal conditions. Now, the heart goes through a complex set of changes in terms of looping of the heart tube and segmentation. And we sort of think of the abnormalities really in terms of conotruncal, outflow tract abnormalities of the aortic arch and all that. And the heart is significantly higher at the 20-week scan in size. So at the 14-week scan, it sort of becomes into a size where you can actually see most cardiac abnormalities. When you use 3D stick, particularly, you can preset your imaging planes with a TUI, which is called tomographic ultrasound imaging. So it bisects the main planes for the major cardiac landmarks. And this allows you actually to diagnose a significant proportion of major cardiac abnormalities in the first trimester. When you're looking at instituting first trimester cardiac screening, patients that have different risk factors have a different level of anticipated incidence of congenital heart disease. And the higher the pre-existing risk for heart disease, the higher also the first trimester detection. And when you look at pooled sensitivities and specificities, it is actually at 84% for major cardiac defects, and this is in a very large sample size. So the importance about looking for cardiac disease in the first trimester, if there are pre-existing risk factors, it is definitely worth your while looking at that, because the major congenital heart defects, you're going to have a high likelihood of identifying in the center that has the expertise. Now, here another sort of overview, when is the best time to actually look at the anatomy? And this is sort of like the checklist of first trimester detailed anatomy. It is basically that the visualization of all the major landmarks is complete by 13 to 14 weeks gestation. The ones that are the hardest ones to see well are the kidneys and the heart. They are better identified or evaluated towards the end of your first trimester screening window. When you're looking at how long an exam takes, 20 to 30 minutes is the average time. And the visualization for structures such as the cerebellum, the face, nose, and lips, spine, diaphragm, extremities, and fingers improves significantly when you look at the 13 to 14-week window compared to 11 to 12 weeks. And part of that is due to physiologic changes and others due to image resolution. So what should you be able to see in the first trimester? Acrania, anencephaly, ectopia cordis, and encephaloceles have a published detection rate of 100%. Severe CNS abnormalities, limb reduction, and megacystis are likely to be detected in the first trimester. Cardiac defects, if you have a dedicated screening program. Less likely to be detected are sort of more subtle abnormalities that become more apparent later on. And some of these abnormalities are really not detectable in the first trimester. But the overall detection rate for major abnormalities from about 13 weeks onwards is over 70%. And this is the optimal timing for a detailed fetal anatomy and an echo. So when you are then counseling your patients about what you're finding and what the next steps are, the next important thing is sort of to consider the reason why anomalies are there. And so this is where I'm going to hand it over to Carol to talk about the genetic testing abnormalities that nowadays not only have the screening tools that give you some idea before you actually do invasive testing, but what has simultaneously expanded is what you can test for with invasive testing. And I'm just going to hand it over to Carol to just take it from here.
Thank you. Okay, let me just, there we go. Okay, so as Dr. Bishat mentioned, basically, first I'm going to touch on just to remind everybody the difference between screening tests and diagnostic tests when it comes to genetic testing in first trimester of pregnancy. So, of course, with screening tests, we never say with 100% certainty that the results are correct. That's the nature of a screening test. We're kind of looking at the population to be able to decide who is at high risk and who is at low risk for the conditions that we're screening for. And as such, we discuss the results as a function of generally, for what I'm going to talk about today, either positive or negative predictive value or the residual risk. Whereas diagnostic testing can generally rule out genetic conditions. There's an asterisk there because in genetics, we never say 100% certainty for anything. Of course, there are some genetic conditions that are not detectable, especially during prenatal life, and that can never be fully confirmed or ruled out, like mosaicism. But when we think about diagnostic testing, it's a test that's like, if we're comparing it to some of the postnatal testing, it's akin to like blood or saliva. So it is diagnostic in its own right. So the types of prenatal screening that I'll be focusing on today primarily are cell-free DNA screening, also known as NIPT or NIPS, but I'll be referring to it as cell-free DNA, as well as a slight touch on carrier screening, just to make sure, because it's something that is recommended to be done. So generally, cell-free DNA screening, I'm sure a lot of you probably are already familiar with this, but there is cell-free DNA fragments that come from the trophoblast cells of the placenta that end up in the maternal circulation. It can be drawn as early as 9 to 10 weeks. Most labs are saying 9 now. Sometimes we still recommend 10 just to make sure that there's a sufficient fetal fraction. Even though this is detectable around 7 weeks in like a research basis, there's not enough fetal fraction to be reliably analyzed until about 9 or 10 weeks. And generally speaking, we perform this screening for aneuploidies for very specific chromosomes, including chromosome 21 to screen for Down syndrome, 18 and 13 to screen for trisomies 18 and 13, as well as the X and Y chromosome, because we know that there can be sex chromosome aneuploidy that's detected. So thinking of things like Turner syndrome, Klinefelter syndrome, etc. So when we're thinking about the performance data of cell-free DNA and the value that it can bring us, obviously this chart here is from a meta-analysis that was performed. And as you can see, the detection rate, the accuracy is very high for the conditions that are screened, which is incredible, because then we get to tell patients the negative predictive value is also really high because the specificity is equally high. There is a false positive rate, however, which is why we never, again, say with 100% certainty. And one thing to note when we're talking about positive predictive value and negative predictive value, it's important to know that the incidence in the general population is what really drives the positive predictive value. So when we get positive results for Down syndrome, they are often much more certain in the same individual than they would be for something like trisomy 13, which is much more rare. And labs will often individually report their own sensitivities and specificities based on their own internal data. And so the positive predictive value between labs might vary a bit. But these numbers here that are presented are from a meta-analysis. So when we are counseling patients, we generally talk about the positive predictive value as a range based on what the kind of general numbers that we see are, as well as the specific numbers from the laboratory themselves. So when we're thinking about special scenarios with cell-free DNA, twin pregnancies are something to consider, because most labs that perform cell-free DNA are, if not all of them now, are validated for twin analysis. Only certain labs can report zygosity, and that is based on the technology that they use. So without getting into, I guess, too much genetics buzzwords, there are generally right now in 2026 on January 21st, because this is bound to be out of date quickly. There are generally two types of platforms that are used for cell-free DNA screening, massively parallel shotgun sequencing and SNP-based technology. So the labs that perform SNP-based technology can report zygosity, the others cannot. And when you're considering twin pregnancy, most labs are not validated to report on sex chromosome aneuploidy. However, they can usually tell you with a fairly accurate guess about, especially in dizygotic twins, if they expect that they are same sex or opposite sex. Another thing to consider is the vanishing twin scenario. So we can still use cell-free DNA in the setting of vanished twin. It's not necessarily something that we can recommend. Most labs are also validated for that now, but it does increase the risk for sex discordance, especially when the twins were, dizygotic opposite sex. So if we're seeing a female on ultrasound and cell-free DNA is telling us that it's a male, we have to consider, was there a known vanished twin that could potentially be messing with that result, because it's unclear how long cell-free DNA from the vanished twin stays in the maternal circulation. There's no established time when it's like quote unquote safe to redraw. And so we always counsel with a few caveats on the reduced sensitivity of the test in the setting of vanished twin. And then last thing to note is higher order multiples. We cannot, at this moment in time, I am not aware of any labs that are validated for multiples higher than twins. So triplets are higher. And so in that scenario, we do still recommend first trimester ultrasound screening, primarily at least a nuchal translucency, if not a detailed anatomy if possible. And there are new applications of cell-free DNA that are coming out. So instead of just screening for those common aneuploidies, like we mentioned, microdeletion screening is also possible on a fairly small scale. Most labs have 5 to 7 microdeletions that they can test for. I put an asterisk there because right now there's no recommendation to be doing any of these really from any of our governing bodies for analysis reliably in the first trimester or in any trimester. But the American College of Medical Genetics and Genomics does now recommend at least offering screening for 22q11.2 microdeletion syndrome or DeGeorge syndrome to all patients based on its population incidence. So that's my asterisk. That is a loose recommendation from ACMG. It can also, there's one laboratory now that's performing aneuploidy screening for all chromosomes, as well as screening for very large copy number variants. We think of it kind of like a screening karyotype for the fetus. And there is also now a couple laboratories that are doing autosomal recessive screening. So specific conditions, so within whatever parameters the lab sets for certain specific conditions, they can screen fetuses through cell-free DNA for recessive conditions. There's one laboratory that I'm aware of that's doing another test for autosomal dominant conditions. It was originally marketed as like an advanced paternal age screen, where they were offering it to, couples who the father of the pregnancy was over 40 or 45. And the thing about that is that the yield is not great because it doesn't happen that often that there are sequence changes within dominant conditions. They're only looking at like 30 specific ones or so. So it's the yield is minimal. It performs better in like scalable dysplasias and other bone growth concerns. And then lastly, there are labs now that are also performing fetal antigen screening. So thinking about like mothers who are Rh negative and checking to see if the fetus is Rh positive. And one lab does have expanded antigen screening capability as well. So if there are any questions about any of those other cell-free DNA applications, I'm happy to answer them, but I will leave it at that for now. To briefly touch on carrier screening, it is widely recommended to perform carrier screening prior to conception. That is always the preferred time to do it. However, not everybody does. And so when that option to perform it before pregnancy is not available, it is recommended to initiate carrier screening as soon as possible, because then it gives us more time to get results, which can take 2 to 3 weeks, and to loop in the father of the pregnancy if not readily available. There are varieties of recommendations when it comes to carrier screening. The first from the American College of Obstetricians and Gynecologists is pretty bare bones in terms of conditions that we're recommending. So they're recommending essentially screening for spinal muscular atrophy, cystic fibrosis, and hemoglobinopathies for everybody as an absolute baseline. Whereas the American College of Medical Genetics and Genomics, or ACMG, has recently come out with a statement saying, has come out with a statement saying that basically we need to be expanding carrier screening from ethnicity-based to kind of a more pan-ethnic approach, so that we are not missing patients based on reported ethnicity, which is not something that patients are great at reporting anyway. And so they're recommending basically carrier screening for everybody for any condition that has a carrier frequency of 1 in 200 or higher in the general population. So with that in mind, other diagnostic procedures that can be performed would be something like chorionic villus sampling. So that's generally performed between 11-ish and 14-ish weeks in pregnancy. Can be performed one of two ways, either transabdominally or transcervically, based on where the placenta is and the provider's preference. And one of the things that we talk about with chorionic villus sampling with all of our patients is the risk for a result called confined placental mosaicism, or mosaicism in general. Because when sampling the placenta, there is a risk that we find aneuploidy in some cells and not in others. And with that result, we can't tell if the mosaicism is just located in the placenta or if it's also being represented in the fetus, because they're from the same, embryo. And so it does leave us in a place where we have kind of an uncertain result and kind of defer to ultrasound to know how high the risk is that there might be mosaicism in the fetus, depending on what the condition is that's coming back mosaic. Of course, when we're doing any diagnostic procedures, there is a risk for complications, one of which could be miscarriage. Here we say that the risk at its highest is probably about 1 in 300, but we do know that there's literature coming out now, some more recent stuff that has even gone as far as to say that chorionic villus sampling risk is quote unquote likely negligible. Would I ever say that to a patient? Probably not, but something to keep in mind. And then, of course, the other diagnostic test that we have is called amniocentesis, which is generally done around or after 16 weeks, as soon as the membranes in the pregnancy fuse. And the risk for miscarriage, again, we say is about 1 in 300 at its highest, but there have been papers, again, that have come out to say that no significant contribution in the prediction of risk of miscarriage from amniocentesis. So, the important thing to know about the amniocentesis is that if we get a mosaic result on amniocentesis, because the amniocytes are directly from the fetal cells, it is more representative of what's going on with the fetus. So even with a mosaic result, we still know that that's diagnostic, whereas that is a little bit more questionable when we do chorionic villus sampling. But that said, both tests are considered diagnostic. So what do we do once we have those samples? The one test that we can do that has been around for ages is called a karyotype. And so that is this visual representation of the chromosomes in their pairs. It can tell us about aneuploidy, if there's any extra missing entire chromosomes. It can tell us if there's any very large structural differences with any of the chromosomes. So we're thinking very large duplications or deletions. It can tell us if there's any structural differences with any of the chromosomes. So if there's any translocations where some information might be swapped amongst chromosomes, for example, but there's still the correct amount. Or other structural abnormalities like ring chromosomes or Merker chromosomes and things along those lines. And so it is still kind of like a bird's eye view of the chromosomes. It tells us about how they look, but not much about how much it contains. And so for that, there is a microarray that's available. And so what microarray does is it kind of gets in more detail about the quantity of genetic information that's present. For example, it can tell us, as you can kind of see in this image, if there's any gains or losses that might be present in a sample without looking at how the chromosomes actually look. It tells us more about how much is there. So it tells us about deletions and duplications, and we do know that there is an increased yield on microarray in the setting of anomalies over that of the karyotype. Of course, the increased yield depends on the affected system, but we do know that generally speaking, the highest incremental yield of microarray over karyotype is in cardiac anomalies, where we're seeing about a 16% increased yield. And so one of the things that we talk about with our patients when we're doing testing is, should we be starting with microarray versus karyotype? Because there's certainly times where either or both would be appropriate. And then when it comes to more detailed testing, so past what we can do on the microarray now, we can do what's called exome sequencing. So exomes being the functional parts of the gene that go into making the RNA that makes the protein. So we're not talking about the non-coding stuff in this case. there's a couple different papers out there about the increased yield of exome sequencing over microarray, and the numbers vary, obviously. I think that the 31% increased yield is coming from a paper in the UK, and they do exome sequencing a little differently. So I guess take it with a grain of salt. But we do see that in multi-system disorders, so like multiple congenital anomalies, that there is about a 15 to 16% increased yield of exome sequencing over microarray. Consistently, what we're seeing is that for an isolated increased nuchal translucency, the increased yield of exome sequencing is the smallest. It's between 2 and 4%, but that is still an increased yield. So something that we discuss with our patients. And then the newest, coolest thing that's out there right now is genome sequencing. So it's not really something that we are doing a ton of just yet, but it is certainly on the horizon and we are fighting for it. The difference between exome and genome sequencing is that we are looking at all of it. So the coding regions, the non-coding regions, and you can see here that the difference between exome and genome sequencing is that exome is about 1 to 2% of the genome. It's a small portion of the genome. So when we're doing whole genome sequencing, we're gathering a lot more data. And because we're looking at everything all at once, this is a test that also can essentially perform the same functions as a microarray. And so for genome, this is kind of a really enticing idea because it can perform a microarray and everything we can do in whole exome sequencing and then some in one assay, which gives us a faster turnaround time, which is ideal. Because genome sequencing is so new, we don't have a ton of information about what the increased yield of genome sequencing is over exome sequencing. There is one paper that I found that said that it was about 0.8%, but that was in very specific scenarios related to some congenital anomalies and autism kind of grouped together. And so it's not a great number. There are some other sources out there that say that it could be as high as like 4%. But again, this is always going to depend on like what systems we're talking about and what anomalies. And so this is something kind of in the works, on the horizon, a little bit of both in the prenatal space right now. So other diagnostic tests that we can consider if and when needed, we can do familial variant testing. So if we know that there's a family history of a genetic condition, or if we know that partners are known to be carriers of the same genetic condition, we are able to perform testing specifically just for those known familial variants so that the answer is more specific, essentially, so that we don't have to use all of the resources to do something that we already know we're looking for. Targeted panel testing is also an option. These are typically phenotype driven. So right now we're really only using these when we have asked a patient's insurance for authorization for exome sequencing and they've denied it. So we try to use targeted panel testing to minimize the number of things that we're looking at, with the caveats, of course, that we're going to there's always a chance that we'll miss something when we do panel testing. Because really it usually contains the genetic conditions that are known and well established to be a part of a syndrome, whereas that's not always what we're picking up on exome sequencing. Sometimes it's a new phenotypic presentation. And then, of course, we can do methylation testing as well. We generally do methylation testing when there are concerns for something like uniparental disomy or certain imprinting disorders. The caveats are that not all laboratories will accept chorionic villus sampling for methylation testing. I know of one that will, but that's because the methylation patterns in the placenta are not as complete and well established as those in the amniocytes. And so there are caveats, of course. So what do we do when we have an abnormal ultrasound and we have all of this information about genetic screening and testing? So first we have to think about the phenotype on the ultrasound and consider the differential diagnosis if we had no other information. And then we look at generally what screening has already been done to tell us what has the patient had, what do we already know, and how much does that tell us? And then if patients elect diagnostic testing, often our first step is to rule out aneuploidy because we don't want to miss something obvious, but that's not always the case depending on the presentation. And then we have to consider if it's not aneuploidy, what else is on the differential diagnosis? So what testing do we need to do based on all of that? So as an example, a theoretical patient here who's a G1P0 who is a 38-year-old, and she on first trimester ultrasound had an AV canal defect and an increased nuptial translucency, or rather the fetus did. We know that she's already had low risk cell-free DNA screening and negative carrier screening. But then she tells us she wants to do a CVS. So what do we do first? Well, we would talk to the patient about a microarray versus karyotype, because we see an AV canal defect and an increased nuptial translucency, and we know that those two things are consistent still with the presentation of Down syndrome. And even though she's had a low risk cell-free DNA, that doesn't mean that she's out of the woods in terms of, like, we haven't completely ruled that out. So that's one of the things that we want to rule out. But we also know that this presentation is consistent with some other microdeletion syndromes. For example, Jacobson syndrome can present with these features. But then theoretically, let's say the microarray comes back and it's normal and the patient still wants additional genetic testing. We can send her for whole exome sequencing, because we know that there are other genetic conditions in the differential that would not have been picked up by the microarray. So something like KBG syndrome, which is a much more rare dominant disorder, or for example, right atrial isomerism can sometimes present with these features, and that is more commonly a recessive condition, and especially one that's not necessarily included on carrier screening. And so exome sequencing is kind of filling the gaps for all of the screening that has already been done that hasn't covered these possibilities yet. And as another example, I know Dr. Bishat just kind of beat me to the punchline on this one, but let's say we have a G2P1, she's 33 years old, and the fetus on first trimester ultrasound has an encephalocele. She's had low risk cell-free DNA screening already in the pregnancy with carrier screening pending, but we know that she and her husband are first cousins. So she elects a CVS, and first we talk about microarray versus karyotype, because we know that while this encephalocele has presented in things like trisomy 18 and 13, it is also noted to be associated with something like a 7q11.23 deletion. So we, are waiting on the results of the microarray, and we get the carrier screening back, and we find out that she and her husband are both carriers of Meckel-Gruber syndrome. So instead of proceeding to something like whole exome sequencing when the microarray comes back normal, we would then proceed to, for example, familial variant testing, because we know that Meckel-Gruber syndrome does present with encephaloceles. And if she and her husband are both carriers of the same thing, then that greatly increases our concern that that might be the condition that's affecting the pregnancy. So just as some examples for how we drive carrier screening, how we drive the decisions about screening and diagnostic testing in the setting of out in the first trimester ultrasound. So I'll hand it back to Dr. Bishat when we stop showing.
Yeah, so after covering that, I think it is important to recognize that the first trimester ultrasound still has a central role in pregnancy management of all pregnant patients. The first trimester platform in that 11 to 14 week window is one that has been established by now for 30 years, and it offers a wealth of information, a wealth of really powerful studies that can basically identify what works, what the value is of the imaging parameters. And that platform has also been expanded to screen for preeclampsia, fetal growth restriction, abnormal glycemic profile, and gestational diabetes. So at the same time, the ultrasound exam in the first trimester has also evolved in quality, both in terms of examining basic anatomy, but also to provide specialized screening, especially for the fetal heart. And if we are armed with a good patient history that identifies the pre-existing risk factors, then we can be highly targeted in the degree of diagnostic testing on the imaging front that we can offer in the first trimester. And this actually sets the stage to provide a far more complete diagnosis of the fetal condition where we can say like, okay, is this an isolated condition, a non-isolated condition? Is it a condition that points potentially for genetic family risks that might have been unrecognized before the fetus as an index case? So for autosomal or for recessive conditions, for example. And we see it many, many times that a detailed ultrasound in the first trimester coupled with the tailored genetic studies really offers a lot of patients with valuable information by the time they go for the second trimester anatomy ultrasound, or identifies a subset of patients that benefit from fetal treatments, fetal interventions, some of which are for the benefit of the mother, and some of which are for the benefit of the fetus. And so the first trimester ultrasound is complemented by what we now have in genetic screening and diagnostic capabilities. And it really sets the stage for precision medicine OB care. And that starts in the offices of the referring physicians, because most of OB practices will have access to these techniques. Definitely history, definitely NIPT, definitely access to first trimester ultrasounds, either in their own offices or by referral to specialized practices that are, certified in the first trimester screening techniques. And so it is really exciting what this sort of integrated platform of advanced imaging, history, personalized risk assessment, and genetic screening and testing opportunities has to offer. So I'll leave it at that and see if there's any questions. Let me just look into the QA. Well, if there's no questions, are there any examples that we can think of? You already presented some.
I was going to say, I think we jumped the gun on that one. I mean, I guess the takeaways are just that we should be using ultrasound and genetics as complementary tools to get a full picture of the pregnancy. I think that's the big wrap-up statement, right?
Yeah.
Labs that perform methylation studies. So typically if I'm sending, am I allowed to use lab names? Is that okay?
I mean, if we're using it for medical, I would think so. I mean, we're not advertising for it, it's just information, right?
That's fair, yes. So the laboratories that I generally send methylation studies on for amniocytes, we generally use Mayo Clinic. And then if you're sending on CVS, the only lab that I know that does that is Chaudhary. I think there might be some other labs that have the capability to do methylation testing on amniocytes, but I'm not sure exactly who they are. I think Mayo is the big one that does that.
Okay. Well, if there is no further questions, then
we have another one. So how often do we see genetic tests or like the fetal sex predicting tests in early pregnancy come back incorrect? Well, the official false positive rates are somewhere around 0.04, false negative rates are about 0.04% for aneuploidy. It really depends on the screening that you're doing. And some of the labs honestly keep the performance data pretty close to their chest. So for something like microdeletion syndromes, I don't know that we have great numbers to know what the false negative rate is. The early, like, I know there's, what's it called, Baby Peak or something, or there's one test that like tries really early to tell you predicted fetal sex, and that one's wrong a lot because if like a man sneezes in the same room as that blood is being drawn for that test, it comes up male. I don't know why. It's just not very reliable. But generally speaking, the sex prediction is pretty good for most of our cases. Fetal antigen and autosomal dominant NIPT regarding like how often it comes back incorrect. That depends on the platform that you're using for fetal antigen. Some platforms have better capabilities than others in terms of detecting something cryptic like an RH deletion or like weak D or something like that in both the mother and the fetus. And so definitely you have more questions about fetal antigen testing. I'm happy to go into more detail about that. But autosomal dominant NIPT, according to the data from the laboratories in like their proof of concept and then their actual outcomes papers that they've put out so far, they say they have a 100% sensitivity and that they haven't had any false negatives, but they also don't have very robust follow-up data. So they don't have a full cohort of patients that have gotten diagnostic testing after birth to be able to confirm it. Are there specific indications for exome or genome sequencing, or is it more of a stepwise process at this time? It depends on where you're practicing. So I know that some of my colleagues are using whole genome sequencing as a first-line genetic test in populations where like people can afford to pay for it is what I will say, because it's still not widely recognized as a test that insurance is willing to pay for often. Generally speaking, we've been using exome and genome sequencing in the setting, obviously in the setting of anomalies. And we typically, our process here right now, because of the way that billing has to occur, is that we do exome sequencing when we have a normal microarray, generally speaking, because most insurances aren't paying for genome, so we're not doing a ton of it here. But we offer patients sometimes, depending on gestational age, when like concurrent microarray and exome sequencing, when there's any anomaly and there are time sensitive concerns, like if they're coming up on a termination deadline that they're considering. And so, but otherwise, generally, we do them in a stepwise fashion more often.
I think I wanted to just make a comment about that. Using exome or genome as a first-line genetic testing is sort of a shotgun approach that is not unproblematic, because if you have a normal appearing fetus or a fetus with mild abnormalities and you get a finding on an exome where how the disease manifests itself may widely vary and might include some things that you can't even prenatally look at or find out about, then you're going to be stuck in a position where you have a genetic abnormality and you're actually not going to be able to tell the parents how it's going to affect their prospective child. And so that is one of the difficulties with using it that way, right? And that's just, I think our exome testing strategy is much more disease driven. When we have a pre-existing like findings on the ultrasound where you say like, well, the likelihood of a genetic finding is probably at least 40% or so. And if you then go through and the array is negative, then in certain clinical settings, especially high drops, right, it would make sense to do an exome. But I think there's more to come on that. The other thing is when you are reporting an exome or a genome, the reporting companies, they will reclassify some genetic findings after a certain time that have been issued as a normal result because it was a variance of unknown significance that wasn't reported out. And so there's also an obligation to follow up with patients if something that was not reported at the time that the testing was done. And subsequently they said, like, no, this is actually associated with some disease, then you got to reach back out to patients. So it's not entirely unproblematic. I would just like to mention.
Yeah. I mean, I will say also that the flip side of that coin is that most patients understand, like when you talk about genetic testing, most of them think that they're getting something like exome and genome anyway. And so running it is usually not necessarily like a patient concern. But most of the labs are reporting out variants of uncertain significance on diagnostic testing these days.
Yeah.
That is not something that happens on screening. So that's one of the caveats with that as well. And the labs, we're here at least for whole exome sequencing, we're generally using GeneDx. And we are waiting for GeneDx to start a prenatal product. We were using a separate lab that we have for whole genome sequencing that we have since subsequently stopped using. And so we're waiting for GeneDx they've announced that they're going to launch a prenatal genome sequencing in February. And so we're waiting for that to come up.
February is soon. Anyway, yeah, it is. Anyway, I think we're ready to wrap up. I think we're at the hour mark. And I want to thank all the attendees, and also wanted to sort of pitch our next webinar that's going to be coming in April, where we'll be talking about, where fetal therapies are moving, what is new, what are some of the new diseases that we are looking at, and not just in terms of invasive, but also medical treatments in pregnancy and all that. So I hope to see as many as possible there. Thank you very much.